TopMedTalk.
Hello and welcome to TopMedTalk. I'm Desiree Chappell, your host, and it is my pleasure to introduce our editor-in-chief of TopMedTalk, Professor Monty Mythen. Hello, Monty. How are you?
Hey, Desiree. I'm good. It's good to be here in person. Having a fireside chat. I'm not sure. We're actually in the wonderful Gullerus room, which makes sense around here, in the Skellig Hotel on the west coast of Ireland. But we've managed to jump into our pop-up TopMedTalk studio by the fire to talk to some guests.
That's
Great.
right. Yeah, we are here during the EBPOM Ireland, EBPOM Chicago meeting. And it is the first meeting that we've had, at least some of us, in person for the last 18 months. So it's super exciting. We've been having some wonderful conversations during the EBPOM meeting. And if you have any interest in checking those out, you can find that at ebpom.org. Now, Monty, we have had a chance to do some of our pop-up TopMedTalk discussions, which has been really exciting to continue that. And today's really no different. Now, yesterday, we had some discussion during EBPOM about novel therapies. And that's one thing we talk a lot about on TopMedTalk is trying to figure out how we introduce, new therapies, new medications, have a conversation about it so we can kind of spread the word and see if it, is of value to us as providers. And so we thought we would move it to the TopMedTalk platform and have some more conversation about a new rescue antiemetic.
Well, we had, as I said, one of these discussions on the main panel yesterday, and it was, the whole audience was very engaged. Initially, it was a big, yawn moment. Surely we're not talking about post-operative nausea and vomiting again, because, the effective prophylactic post-operative and nausea vomiting treatments are pretty universally used in our world now, and they are highly effective for very many patients. But it was when they said, well, hang on a second, what about the rescue antiemetic? And that's that patient that those of us, because I work on the sort of surgical high care area and surgical ICU, it's that patient who post-operatively, often when team anesthesia has gone, that's there and has got that secondary nausea that is now resistant to those prophylactic treatments. So we're high interested in the reprofiling of a new drug in particular that's come along that is there to specifically rescue those patients.
That's right. Well, Monty, we love to have multidisciplinary conversations here on TopMedTalk. And, we talk to a lot of anesthesia providers. We talk to a lot of surgeons, nurses. One group that we haven't had as many conversations with are the pharmacists, right? And when we talk about novel therapies, it's so important to bring them into the conversation. There's a perspective that pharmacy has on all of these things that I think is really useful to talk about.
So and I think it's quite representative of many practices now, and I say we in the context of our surgical high care and critical care environment, we have a multidisciplinary ward round every day of the week, and a key component of that is our pharmacy colleagues. They're there as professionals to advise us. We occasionally make, believe it or not, prescribing slip-ups despite the electronic health record, and they give us little nudges about dosing and potential, interactions with other drugs. But they also really help us with regards to novel therapies, because not only is there benefit we want to bring to the patient, before we understand all the side effect profiles, there's the potential for harm. So we regard them as absolutely key players.
Well, without further ado, Monty, I'd love to bring in our guest. We have Trisha Myers, who's a PharmD. She's adjunct professor at Texas A&M College of Medicine. Trisha, it is so wonderful to have you here. Thank you so much for joining us on TopMedTalk. Tell us just a little bit more about yourself.
I'm a PharmD, a pharmacist, and I practice as a regional director of pharmacy. I was over 3 hospitals for many years. But in addition to my pharmacy role as a pharmacy manager, administrator, I also had my clinical practice in the field of anesthesiology. So that's my favorite drugs, my favorite go-to department to look at drug use, drug interactions, drug cost. And I developed a rapport with our anesthesiologists locally, but also nationally. I was the first pharmacist named to the Anesthesia Patient Safety Foundation several years ago. I co-authored the consensus guidelines for postoperative nausea and vomiting with T.J. Gann and many other well-known anesthesiologists. And we are on our 4th iteration of that publication. It just came out in 2020. Most of my research and publications is around drugs of anesthetic interest.
as an anesthesia provider as well as a critical care doc, I think things have been fairly quiet on the novel therapeutic interventions in our space for a few years, but suddenly things have got quite exciting again. We actually had a whole session yesterday discussing novel therapies. Looking through your lens, do you see it the same way?
I do. And the emphasis now is on the treatment side of postoperative nausea and vomiting. There are so many studies on prophylaxis, but very few on treatment. And in our guidelines, that is one of the research agenda topics that we recommend that when anesthesiology providers, pharmacists are doing research on PONV, that you look at the treatment.
Because I think we're all familiar with our toolbox for prevention now, and the guidelines over the various iterations have helped us enormously to appreciate dual therapy and triple therapy and identifying at-risk individuals. But we still hit the buffers of saying we've deployed everything in our toolbox, our pill box, our needle box, and we still have some patients who are nauseated in particular. Because certainly from my experience, the vomiting patient, day 2, day 3 post-operatively is a bit more straightforward to sort out. But the much more common thing is the nauseated patient, that grey patient feeling really wretched, that we need something to try and rescue.
And our guidelines do review on the differences of the prophylaxis versus treatment, nausea versus emesis. We try to help the frontline practitioner with these guidelines, and each guideline we've written, we try to just describe what our update is for that topic, since, again, we've had 4 different publications on the topic. I think another area of interest is the side effects. I think we're paying much more attention to the side effects of these antiemetics. We started recognizing some of the severe side effects in the early 2000s, but prior to the 2000s, we felt antiemetics were fairly safe drugs. There was really not a lot of concern. And in the 2000s, that's when we started reading about the FDA black box warnings. We found out about the severe tissue damage of one of the antiemetics, and I think it gave us an overall awareness. Also, I think with many of the antiemetics, we found that agents that were causing sedation or EPS could actually be prolonging hospital stays or PACU stays. And the landscape has changed from that time period years ago to now. Now we're much more concerned about turnover. We're more concerned about patients boarding and taking up value space. We're much more concerned about enhanced recovery protocols. And it's important that we look at these side effects, because these side effects can delay our patients in the PACU setting and delay discharge.
I think it would be of value to walk through what we currently are doing when it comes to rescue. What are the medications we're using, and what are some of the things that we're struggling with current kind of standard operating procedure?
Well, we're using the same antiemetics we use for prophylaxis. The problem is we've studied them very carefully for prophylaxis and not necessarily for treatment. We don't really know what some of the best antiemetics are for treatment. There are very few studies outlining the best antiemetic for that specific indication. We do know the new drug amisulpride has done studies on treatment and looks very promising. But the other antiemetics, we just assume if they work for prophylaxis, they'll likely work for treatment. But we don't know if that's true or not.
Well, traditionally, I'm a nurse anesthetist, a certified registered nurse anesthetist, CRNA in the States. And, traditionally we were using IV Phenergan. If someone was experiencing nausea and vomiting, we'd use, Compazine. That's kind of fallen out of favor. But typically we'll use Compazine as kind of next level if we've already tried a second dose of Zofran, which, usually doesn't work. Is that kind of what you still see?
Oh, we do. We know from several studies that repeating the same drug from the same class isn't any better than the placebo or saline. This is a study done by Anthony Kovac where he looked at ondansetron, gave it prophylactically, and then gave it after the patient reached the PACU. And he found, as compared to saline, that there was no difference. So we know repeating doses of the same antiemetic are not effective.
Just to be clear again about this, ondansetron is undoubtedly a huge step forward as a designer drug for the prophylaxis of emesis and nausea. It's back in the 90s when it was invented, very specific targeting of the 5-HT3 receptors in the gut and the brain. So we're not saying that's not a huge contribution. It's once the patient has had that and they're now still in trouble and you're looking for treatment, you need a different route in. You need a different set of receptors because you've done your best to deal with the serotonin side of things. You've probably got to switch back to the dopamine side of things.
Exactly. So there are 5 receptor sites that we think activate the nausea and vomiting. And what we are finding is that once you take care of the one receptor with a antagonist, then you need to move to the second. So even if you're looking at combination therapy, you wouldn't want to use 2 drugs of the same pharmacological class. You want to use a drug like ondansetron, the 5-HT3. You might want to use an antihistamine, or you might want to use an NK1, or you might want to use a dopamine antagonist to make sure you cover as many receptor sites as possible and not leaving one that's not been covered. Then when you're ready to use a treatment drug, you should look at what you used as a prophylaxis and again, try to use a drug from the different pharmacological class.
Yeah, and I think the story here, as opposed to ondansetron that we're referring to quite a lot, because that was a beautiful piece of biology where they developed the drug specifically to do a job using, radionuclide labeling and very specific experiments. I know a bit too much about it. Here, as I understand, they said, well, actually, we'd really like to have a D2, D3 receptor-related drug, and we have some of those in our toolbox already. So we know the drug you're referring to in Europe for a long time, but for a very different indication. So this is a redeployment, and correct me if I'm wrong, of a drug that's been around for a long time, but in a different dose for a different use. Have I got that correct?
Yes, that is correct. Amisulpride, or barimesis, as it's labeled in the U.S., was used as an antipsychotic. It's a dopamine antagonist, and at a much lower dose found that it can alleviate postoperative nausea and vomiting. The company decided to do most of the studies, even though they did prophylactic studies, they did studies also on treatment and found that it was very effective. And this is something that we've always felt the dopamine antagonists are strong drugs. In fact, droperidol was probably the number 1 preferred drug by anesthesiologists for many years as a prophylaxis drug. Of course, it fell out of favor in the early 2000s because of the QT prolongation issue. And that's something that we look at very carefully now on the treatment drugs, again, because anytime a patient suffers from a drug interaction, adverse event, or a side effect is causing that prolonged stay in the recovery room. And if we're discharging the patient to home, if it's a day surgery, we certainly don't want to have those lingering side effects with the drug. But even if the patient is staying in the hospital, we certainly want to make sure he's ready for discharge or she's ready for discharge as soon as possible. And so that's why it's important when you're selecting these drugs, you not only look at what drugs you've given prophylactically to decide what you're going to give for treatment if the patient has nausea and vomiting after surgery, but you also pay attention to the side effects. And you mentioned promethazine. So promethazine was a drug that we used often. It did have efficacy, but what was found is that it had caused severe tissue injury. It was a drug that is called a vesicant. And a vesicant is a very irritating, not only to the tissue surrounding the injection site, but also the blood vessels. Promethazine, drowsiness is the most prominent CNS effect of the drug. But the drug also has some antihistamine, anti-motion, antiemetic, but it also has some strong sedative effects. The reason it's a vesicant is probably because maybe there's some phenol in the formulation. And it has a pH of about 4 to 5.5. It's typically been given IV push, where it hasn't been in the past, but that's when those reports of severe and tragic local injuries to patient occurred. It is caused because there was infiltration or inadvertent intra-articular injection. And so those patients experience a sensory loss. Some patients experience paralysis in that area, necrosis, gangrene, and patients had to have amputation. There were several cases that were very tragic that were cited with the Institute for Safe Medication Practices. A 19-year-old who went into the emergency room just not feeling well was given promethazine, and she lost her thumb, her forefinger, and part of another finger. There was another individual, a young woman who was a guitarist, and she had to have some amputation because of the promethazine necrosis that occurred. So a black box warning was placed on that drug, and many hospitals actually took the drug off their formulary for use. So that's a concern because you still can use promethazine as long as you abide by the black box warning and try to avoid the issues that likely caused this injury to the patient.
I'm assuming the way you're framing it, that is not an issue with amisulpride.
It is not an issue with amisulpride. Amisulpride has a fairly safe profile as far as side effects. Although the package insert states it has some QT prolongation, the studies did not find that was an issue, and it can be given. It has a set dose of 10 milligrams for treatment. It has been shown by studies with Candiati and with Habib that it has produced a decrease in postoperative nausea and vomiting compared to placebo.
Trisha, I have a question for you. So we go to our P&T committee, and we're asking about how this is something we're very interested in. And one of the things we get a lot, and as someone who has these conversations, it's like, well, is there something else in this class that works or the efficacy is similar, or and of course cost. So how do we need to frame this when we talk about comparison, especially comparison to other medications that are used specifically for rescue? How do we need to frame that conversation when we go and talk about this? Because the side effects are very real, and there are other drugs in this class, but they're not really appropriate for what we're trying to do, is how I understand it.
Well, as pharmacists, those are things that we look at on a daily basis. It's our job to make sure when a patient receives the drug that it's the most optimal drug. And those things include looking at their renal function, their liver function. We look at their allergies, their contraindications, maybe their disease state. We also look at dosing adjustments. Is it going to be difficult for the nurse to have to do a calculation? Because the more steps you add, the more opportunity there is for error. And we do monitor drug interactions. So when we go to P&T, we sort of look at what the ideal drug would be. And when we look at an antiemetic, the ideal drug is one that would be have proven efficiencies, that would have a rapid onset, would have the duration that you would want, especially an antiemetic. If we're using it for an outpatient surgery, we'd like to have an antiemetic that has a longer duration, because the patient then, once they leave the hospital, will have that coverage for PONV. We look for simplicity of dosing. We look for a low profile for drug interactions and contraindications. We look for a reasonable cost, but our primary emphasis is on a strong safety profile.
Trisha, I really appreciate you taking the time to talk with us about this particular medication and specifically about the side effects. Because, again, I hate to give my patients something that's going to prolong stay. The thought of having to give a Phenergan or, even droperidol. I know a lot of people love it and say it works great. It's just, I've just seen too many times where it's not, it doesn't look pretty. That's for sure.
Yeah, no, there is a concern with droperidol, the sedation, the EPS, but the QT prolongation is also a major concern that we've seen. We know that amisulpride, compared to other dopamine antagonists, has this unique pharmacological properties that result in a more favorable safety profile. It's got less likely to cause EPS. And again, in the studies, there was not any concern about QT prolongation, even though we had to add, or the company had to add it in the side effect profile, but it was only seen in higher doses. And again, we're using 10 milligrams. The doses that were used in Europe were much higher doses when they used it as the antipsychotic.
Gotcha. And I think that is one thing I remember from our conversation with Drew Riddle yesterday during the EBPOM session, that normal dose would be 5 milligrams, but for that rescue, it's the 10 milligrams. Is that correct?
It's correct. The 5 milligrams is for prophylactic. The 10 milligrams is used for the treatment.
And that's what we have for approval here in the U.S.
Yes.
Oh, well, Trisha, thank you so much. I really appreciate it. Monty, any other questions?
No, it's been great talking to you. Thank you. Thank you and all your colleagues for your work and all the help that you give us.
Yes, absolutely. 100%. Trisha, have a wonderful day. And thank you for listening or watching here on TopMedTalk. If you want any more information, you can find us at topmedtalk.com. We're also on your favorite social media platform, Twitter, LinkedIn, Facebook. You can follow us on there and get up to dates every time we have a new conversation, just like this one today. Thanks and have a wonderful day.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.